So welcome to the Traumatic Brain Injury Rehabilitation Unit. I want to focus on your safety first. That's our utmost concern. And as you probably know, TBI patients can be aggressive. And actually when a TBI patient is in a post-traumatic confusional state or post-traumatic amnestic state, their confusion and their physical aggression can actually be at their worst before it gets better. And that's actually a sign of their healing, that they've broken out of their disorders of consciousness. But you still need to be safe. So the way we like to teach approach of a potentially aggressive traumatic brain injury patient is to first recognize the different language that we use to describe agitation. So we would start with just a motor restlessness if the patient is touching their lines, grabbing at things, and just motor restless, which we call akathisia. And so we just want to say restless. We don't want to overuse the term agitation all the time because that causes the whole clinical team to overreact with too many medications. And then the next would be irritable. And there's no physical violence or shouting, they're just irritated. I think everyone knows what irritable is. And then you would start to use agitation when there is yelling or pushing, and then aggression if it's violent and your safety is at risk. That's when we bring in the heavy medications to control the situation right away. And in someone in a post-traumatic confusional state, they're not going to be using the higher, more advanced parts of their brain. They don't have access to it yet. So they're going to be running on the limbic system, or in common language we may say reptile brain. Just a very reactionary, emotional, reflective type of reaction where your tone and your body language is going to be the most important, even more than the words that you say. So we're taught to not baby talk to the patient because that's demeaning and condescending, and that can irritate the TBI patient more, but just talk to them like a regular adult. Talk as much to the patient as an adult as you can. Don't raise your voice and don't be physically threatening to the patient. I like to be low, often lower than Kevin's going to pretend to be the TBI patient. I often like to be lower, but I don't want to put myself in physical danger in case the brain injury patient is delirious or might be violent. So I wouldn't face like this and expose my face, neck, chest, organs to the patient. I would always be sideways, and I would always usually have a hand either on their hand in a very, gentle human touch type of way, or you can pretend that you're pondering, but this is a defensive position, and being sideways, your arm and your thigh, it's all protecting your organs. Okay, so you don't want to stand over the patient and scold them. That's very threatening because we're talking about leveraging the limbic system. And so what's even more effective to a patient's agitation and irritability, more effective than the medications that we can give, is their sleep. So the less times that we interrupt the patient's sleep at night, and the more we can get the patient on a regular circadian rhythm, the better they're going to have control of their emotions and agitation, and the less medications we have to use, the less polypharmacy we have to use, the more awake the patient will be during the day. So during the day, we want blinds, curtains up, lights on. We want the patient awake during the day so that they have enough sleep inertia and sleep momentum at night, so we don't have to overuse strong antipsychotics to put them to sleep. And then when the patient has better sleep, they have better willpower and they are more able to listen to your advice and your counseling. So that's all I have.
So for patients with TBIs, they're not necessarily going to be able to ask you for everything that they need. So making sure they have everything in view, like their urinal or the commode or food, water, just all the necessities and their call light, anything that they're gonna need, it's really important to make sure that they can see it. They're not always gonna be able to say, hey, can you help me? And so having those visual cues around them is gonna be really important. Also, when patients are with TBI, on that same note, they're not always going to be able to ask for help. They have a lot of difficulty recognizing their own deficits. So they're going to be impulsive. They're not going to have good safety awareness. And so being close by and making sure that you're within an arm's reach is really important, because they can just get up and stand up without warning and fall. So you need to be close by to them to make sure that they're not going to do things that are going to jeopardize their safety and cause fall risk. Cool.
Hey guys, I'm Jackie, physical therapist. I just really want to emphasize the use of the whiteboard. We mark that for your training purposes as well, so that you have a reference of how much mobility, how much assistance that patient needs. So if you look at the whiteboard, we've got total assist, max, partial mod, and then supervision independent. So obviously if they're like at a total assist, you're probably going to need another person for safety. Total assist usually indicates that they have really low trunk control. A maximal assistance is going to need, their trunk and their legs needing assistance to get to the edge of the bed. So you may also need a second person. It just depends on how much they're able to move, or if there's any plegia or paresis on one side, and then how cognitively aware they are. Sleep also has a lot to do with it. If they get a good night's sleep, it's going to be a lot easier of a transfer. And then when you get into partial and moderate assistance, usually, their balance is going to need some work, so you may have to really still be hands-on and give about 50% of assistance with their balance and their trunk control. Once they're, at the edge of the bed and you see that their trunk is good, they're responding appropriately, and they really don't need too much help, you're at a supervised level. And then obviously independent, they probably have some room clearance at that point. And so that both are for that.
All right, so I'm Annie. I'm one of the physical therapists. Jackie just talked to you about deflating the mattress. I'm going to show you some positions where you can stand so that you don't get kicked too badly. So don't stand here at the end of the bed and try to get them out of bed, or else they can kick you. So you want to have your hands ready so you kind of block yourself. And if they want to help them up, I'm gonna always have my hands ready. I'm gonna talk to them nice and calmly, like, hi, I'm Annie, I'm your physical therapist, I'm here to help you. All right, I'm gonna position my body close to them. If they need more help, I'm gonna be right up on them. If they don't need a lot of help, I'll kind of give them the space. A lot of times they might stand up really quickly, and I'm gonna be here right next to them, okay? I usually kind of hold on to their arm if they're okay, but their balance usually is off. And so they might fall over, so you want to be steady them and say like, hey, it's all right. I always orient them. You're here at the hospital. I'm here to help you, and we can go for a little walk. Okay. Okay? Why don't you have a seat? So I always have a nice, gentle kind of touch with them. If I get angry, they're gonna get angry back at me. So just want to go.
I don't want to be here.
Sometimes they get a little irritated and just want to start moving. So I'm going to make sure, like Jackie referenced, look at the board, how much help they need as they're walking. If they need min assist, I'm just going to hold on to their arm. If they don't have any hemiplegia, and we'll just go for a walk. You can walk them around the unit. You can ask us if they can walk. If they just need to get in a wheelchair and wheel around, you can wheel them around the unit, and that can help calm them down. So to protect yourself, don't stand directly in front of the patient. They can really get you in the face, come to the side of them, and be able to kind of keep your hands ready and steady from the side so you're not getting punched directly in the face.
Hi guys, my name is Arlena. I'm an occupational therapist, and today I kind of just wanted to go over the importance of engaging your patients in familiar tasks during their stay here. A lot of these tasks can have them include engaging in their activities of daily living, which includes a lot of self-care activities, oral hygiene, brushing their hair, or any like grooming tasks, getting dressed, which includes putting a shirt on, pants, socks, shoes, getting them to the toilet or going to the shower. And why I kind of wanted to talk to you about this is that it's important to have them engage in these familiar everyday tasks to help promote brain recovery while they're here, which is especially important for our TBI patients. And also, while you're here, especially if you're a sitter, you're always going to be in the room with them. So it's going to be really important to help create their room into like a safe space for them and making it a homey environment where they feel comfortable. So this includes by educating them to use the call light while they're here to promote some of that functional problem solving. So teaching them like if they need to go to the bathroom or if they need pain meds or anything from the nurse, encourage them to use that call light as much as you can rather than you calling the nurse, have them try to do it if possible. If they have a supportive family environment, maybe see if their family can bring in any clothing for them, something that's their own clothes rather than being in a hospital gown or in the hospital shorts. Maybe having them be in their own clothing will make them feel more comfortable. So if the family's there, great, have them bring clothes. See if they can bring shoes if the patient has really good mobility levels. If they're ambulating, shoes will be really beneficial for them while they're here. Usually sneakers or any type of tennis shoes would work. And for their clothing, if family is able to bring it, if you guys can maybe have the clothing placed closer to the patient so that the patient is able to independently retrieve their clothing instead of having it being inaccessible to them. So if the patient doesn't have the best mobility levels, maybe place the clothing at the bedside so then they can use a reacher, or even if they're able to move around in the bed, they can reach it at the end of the bed. Or if they're ambulating, maybe place the clothing into their bedside table or on top of the bedside table, and then they can ambulate and go ahead and retrieve the clothing. And I think that's it. Thanks. Okay, something else I kind of wanted to talk to you guys about is utilizing the therapy schedules that the patients have in their rooms. I think it'll be really good to use the schedule so that the patients are kind of on this routine and kind of know what's coming up during their day. So like have them know when they're gonna have their next OT session, physical therapy, speech therapy, just so they can keep track, and hopefully they've gone to the bathroom before therapy or they ate already, so then none of that disrupts their therapy time. Another thing is I know that a lot of the rooms have a whiteboards in there, so if the patient's having trouble with their memory or if they're having any additional cognitive deficits, feel free to utilize that whiteboard as much as you can and orient the patient to the time of day, the month, the year, and who their primary therapists are, so that every day they get more and more with their increased awareness and to help improve their memory. And feel free to use the calendar too, so that they can keep track of the month and then the specific day, like whether it's Monday, Thursday, Friday, whatever, and then the specific date and then the year.
Hi, my name is Michaela. I'm one of the speech therapists here. As speech therapy, we have tried to create different forms of communication to help our patients with cognition and also eating. One of the ones we love is the memory book. This really helps with just even orienting our patients. So one thing that I like to do every time I come into a patient's room is just talk about where they are, who they are, what the date is, and the different doctors that they have. So that could be something that you do with them. And then also every day, whether you're with them or the other therapists, try and fill out what you do with them and then try and have them recall what they did throughout the day as well. Another thing that's really important is the diet signs. If you could read those and make sure that you're following all of the safe swallowing strategies, and then anything that's written at the bottom, we'd be very appreciative. A lot of times we write what happened in their most recent MBS or swallow study. And those things are important because if we're not following them, they might choke or aspirate, and we want to make sure that we're not giving them any unnecessary choking or pneumonia. So make sure that you read through those. And then also it helps family know the diet textures that they can eat as well. So if you're seeing food at bedside that they're not supposed to be eating, you can reference the diet sign and make sure that they're eating the foods they're supposed to be eating. So thank you. Another thing to look for is sometimes we leave homework for patients. So if you are wanting to do an activity with them, open the memory book and just look inside this first pocket. You might find that there's word searches or cancellation tasks or something to kind of spend time with them with. While you're doing it with them, make sure you're just giving them slow directions, giving them time to process what you've asked them to do, and then just helping them if they need help with finishing the task. And that'll really help with their problem solving and memory.